Good evening, all. Good evening, my teachers, my mentors, senior colleagues, and colleagues. I hope my slides are visible now. Okay. So I will be making the talk based on the SICS approach in the management of coexisting cataracts and glaucoma. I have no financial conflict of interest. Cataracts and glaucoma are both limited causes of visual impairment and blindness, and both diseases may coexist in the same patient as discussed by the together they constitute about 60% of blindness in Nigeria. But the impact of cataracts on glaucoma evaluation is that it worsens mean deviation across all visual fields being tested. To a lesser extent than deviation, it also affects the visual field index, affects the characterization of scotomas. For example, a centrally located posterior subcapsular cataracts can present as a paracentral or central scotoma visual field. And if the proper lens evaluation was not done at the slit lamp, this may be falsely interpreted to be as glaucomatous damage. It also causes underestimation of the thickness of the retinal fiber layer, and it impairs proper slit lamp biomicroscopy. So what's the goal generally for cataract surgery? One is to optimize vision and give the best possible quality of life in our glaucoma patient. As Dr. Gary ably mentioned, 1 out of every 8 glaucoma patients blind from the national survey, it was as a result of cataracts and not the glaucoma. It also enables continued monitoring of glaucoma patients. So small incision cataract surgery versus phaco emulsification. Phaco has a lot of advantages over small incision cataract surgery, but the two advantages SICS has over phaco are: one, the cost effectiveness. It costs far less than even a third of the cost for phaco emulsification, and it's less machine and technology dependent. So, especially in our environment, developing country, with a significant people paying out of pockets, which influence the cost, and also the need for repair of the machines when they break down are quite difficult in our setting. Visual outcome is comparable between these two groups. Several studies have shown that. For example, the study by Gogati et al. Did a meta-analysis of 11 similar studies with a pool of about 76,000 eyes, showed that the unaided and the best corrected visual acuity were similar in both groups. And the only difference they noted was that there was significantly less astigmatism in the phaco group than the SICS group. But this difference was not enough to influence the final visual outcome. So small incision cataract surgery in glaucoma patients. This can be done when only cataract surgery is needed in an eye that has not had a previous incisional glaucoma surgery, or performing a cataract surgery after an incisional glaucoma surgery, or performing a combined cataracts and glaucoma surgery. I want to further discuss my point based on pearls, which I titled "Important Pearls in the Management of in Performing SICS in Glaucoma Patients." And I listed 6 pearls here, which subsequent slides will elaborate a bit more on them. One, the proper evaluation and patient selection is key pre-operatively. Some of these have been alluded by the previous speaker. Avoid increase in intra-orbital pressure. Must be proficient in SICS ab initio, the setting of operating in a glaucomatous eye. Be able to perform SICS at different sites. Be able to do that even using the temporal approach. Protect the cornea endothelium as much as possible, and aim for complete cortical clearance. So for the first pearl, a proper evaluation of patient selection. First of all, observe all the usual pre-operative preparation for cataract surgery, but also ensure you have good pupillary dilatation that you are comfortable with in operating an SICS. In these cases, these are not the patients that you'll be struggling with prolapsing the nucleus into the AC. By doing this, you cause irritation to the iris and induce further inflammation. For patients who are on miotics, better to stop these miotics drugs days before to allow for better pupillary dilatation at the day of surgery. For those who had previous incisional glaucoma surgery, it's important to note the location and the extent of the bleb and to ensure you have enough surgical field away from the bleb when you want to perform the SICS, and these are done in the pre-operative evaluative state. For example, a bleb located in the superior temporal aspect, you may have a restricted area to work with in the temporal area without traumatizing the bleb, and you may need to go inferotemporal. In situations, extend your incision from 6 to 10 o'clock as against from usual 7 to 11 o'clock if it's a strictly superior base bleb I want to do a temporal SICS. You also need to note the type of cataracts, and this will help to predetermine the size of the scleral incision that is made for scleral tunnel. A predominantly nuclear sclerosis is usually a bigger and harder nucleus, and as such you need a longer scleral incision than a predominantly cortical cataract. So this will enable you to gauge if your available operating field is adequate. All these decisions can be made pre-operatively when evaluating the patient on the slit lamp. One needs to avoid increasing intra-orbital pressure. The retrobulbar anesthesia is a complete no-no in these sets of patients, and this is because retrobulbar anesthesia results in increase in intra-orbital space in the retrobulbar area, and this will impair the optic nerve perfusion and further cause optic nerve damage, which is critical in glaucoma patients, and even worse when you are dealing with advanced glaucoma. Occasionally, this may even result in wipeouts in patients, and you see patients having wipeout syndrome. The next day after the surgery, you're wondering where the problem or where the issue came from. So, tend to do topical anesthesia, of course, with intracameral preservative-free lidocaine. And if this is not possible, or the expertise is not there, a posterior subtenon is advocated, or at least a peribulbar anesthesia with minimal volume of anesthetic agent as much as possible. Or you can go to general anesthesia if that is what is comfortable for the surgeon and the patient. Also, one must be very proficient in SICS ab initio before attempting to perform SICS in the glaucomatous eye. This enables one to avoid prolonged surgery. Prolonged surgery tend to bring about increased inflammation post-op and the attendant problem in the glaucomatous eye. Minimize complication as much as possible. A PC rent is a nightmare for subsequent management of glaucoma patient, so you want to minimize complication. Where you have a PC rent while performing your cataract surgery, you have the problem that may result post-op with one, prolonged inflammation, gradual uncontrolled intraocular pressure times gradually, and the need for more medication or even the need for incisional glaucoma surgery to control the pressure because of the PC, even without vitreous loss. So aim to avoid complications as much as possible in these eyes. Location, be able to perform SICS as any site possible that is available for one. So aim for temporal approach in an eye that has not had any incisional glaucoma surgery, and this is to keep the superior conjunctiva and sclera undisturbed for possible incisional glaucoma surgery later. Very proficient in a superior site SICS before translating to performing a temporal SICS. And this is because the forehead and the superior orbital rim that is available to help stabilize the surgeon hand is not available in the temporal aspect. So this makes the surgery a bit more technical. So be proficient in the superior side the surgery first before one migrates to the temporal side. When you master the temporal side, then you can start performing SICS in the glaucomatous eye. And this temporal SICS can be performed with or without the use of a lateral rectus suture. You don't use a lateral recto but I feel it's clouds the field of operation a bit when using it. Aim to protect the cornea endothelium as much as possible. It has been shown by several studies that loss of endothelial function occur at a faster rate in glaucoma patients than age and gender match control. Patients who have not had glaucoma surgery matched with controls that have been noted to have less functioning endothelium, cornea endothelium. And this has been attributed to one, the recurrent elevated intraocular pressure present in the glaucomatous eye, causing some injury to the cornea endothelium, and also the use of preservative containing topical anti-glaucoma medication all result in suboptimal functioning. Now, cataract surgery on its own also affects or causes injury to an endothelium. So when these two are present, it's very obvious that one has to be very, very careful when performing SICS or any cataract surgery in a glaucomatous eye. And this can be reduced, the injury can be reduced by using judicious viscoelastic. I tell my residents that they should not minimize the use of viscoelastic when operating for performing SICS in a glaucomatous eye as much as possible. Use the viscoelastic and aim also not to allow the anterior chamber to collapse during manipulation. The fluctuation in the anterior chamber on its own also causes some level of injury to the cornea endothelium. And this can also be further achieved by combining cohesive viscoelastic and dispersive viscoelastic during your surgery, where the cohesive viscoelastic helps to maintain the intraocular pressure and reduces the possibility of collapse of the anterior chamber during manipulation. The dispersive viscoelastic usually applied after you have applied the cohesive superiorly coats the cornea endothelium and prevents or minimize injury to the endothelium. Secondly, one can perform a Blumenthal surgical technique. That is where all the surgery is performed under AC maintenance. And this is my video actually taken with the phone sometime last year. It's a straightforward cataract surgery. Patient doesn't have glaucoma, so we did the temporal superior approach for the SICS, and just to show the Blumenthal technique where the viscoelastic was not used at all. It's a compressed video of about just 30 seconds or less than that. My residents have the full video for their view and training. So my side port is made at 5 o'clock where the AC maintainer will be inserted. Capsule has been stained, air bubble, but now the AC maintainer is there, press is completed, nucleus prolapse into the AC and nucleus is delivered, IOL inserted, all under the AC maintainer without the use of viscoelastic. In this case, the AC remained maintained throughout the surgery. Sixth pearl is to completely remove the cortex when operating using the SICS. These are not eyes whereby there are some few peripheral cortical matter that you want to leave and say with time it will resolve and will have any problem, because a retained cortical matter induces prolonged inflammation, which would result in prolonged steroid use. And we know about 95% of primary angle glaucoma patients are steroid responders. So you may have elevated intraocular pressure from steroid response and uncontrolled intraocular pressure, or the need for more medications or even surgical intervention to manage them. So aim for 100% cortical clearance as much as possible, but at the same time, not compromising safety and the risks of complication. So we combine in situation whereby there is a need to perform combined SICS and incisional glaucoma surgery. We are faced with this when we have both significant cataracts and glaucoma that needs a surgical intervention. This can be done sequentially, as Dr. Ilea mentioned earlier. It can be cataract surgery followed by trabeculectomy, or it can be a combined cataracts and trabeculectomy, which can be single site surgery or two-site surgery. But unlike phaco trap, where two-site surgery is more preferred because the phaco emulsification is done through clear cornea, For combined SICS trap, the single site is more preferred because at the end, the trauma to the conjunctiva is minimal as compared to two-site surgery SICS trap. Perform a two-site surgery SICS trap, then that means you're going to raise a conjunctiva peritomy from temporal aspect to perform the cataracts. Then now come superiorly and do the same to carry out the trabeculectomy. That way it causes more inflammation over the ocular surface. But unlike the phaco traps where the phaco emulsification, the whole aspect of the cataract surgery is done through the cornea, the conjunctiva and sclera are not disturbed in the first phase of the surgery. So single site is more preferred in combined SICS trap as against two sites for the phaco SICS trap. This is another video of mine showing the combined SICS trap, also taken by the phone surgery sometime last year. I usually give the subconjunctiva xylocaine superiorly, so I'm showing why. And instead of doing a straightforward SICS tunneling, I create a scleral triangular flap, and this will help me post-op in optimizing the outcome of the trabeculectomy aspect, because I can needle the bleb, raise the flap, unlike doing a straight or a curved SICS incision and performing the deep block and PI. In that case, those post-op manipulations will not be possible. But in this, you can do that. For better stability, you can have an assistance to help retract the scleral flap. In this case, did the surgery. The normal reusable suture can be placed as necessary. So after suturing the flap, close the conjunctiva with 2 wing sutures and 2 mattress sutures. Just a compressed video also. So small incision cataract surgery and minimal invasive glaucoma surgery. Can you do both? Yes, all MIGS that you can perform under phaco emulsification can be performed also under SICS. Be it the subconjunctiva MIGS, the angle MIGS, or the suprachoroidal MIGS, they can all be performed with the SICS. But the drawback is the cost, where on the average, the cost of SICS is less than $200 in most centers in Nigeria. The cost of MIGS are in several $100 to thousands of dollars. So you cannot add an add-on surgery that is far more expensive than the main surgery for the patient to cover. And also taking note of the socioeconomic status in our country, where vast majority of people are living below poverty line, 95% of us are still paying out of pocket. It is not feasible to have SICS MIGS. But in 2019, Daniel LaRoche and co. presented a paper, published a paper where they did a modified Glaucoma blade goniotomy using a 23G straight needle. And instead of using the Glaucoma blade is about 140,000 naira, and the needle is less than 500 naira. So you can use same needle to do a goniotomy and perform your SICS. And they had good outcome with their papers, with the report they gave. So you can perform a simple goniotomy with the SICS, and our patient will still benefit from the effect of MIGS when we are performing SICS in them. By way of concluding, I would say detailed pre-operative evaluation is important. It helps, in this case, categorizing our patient appropriately and plan ahead before the surgery date on special precautions that we need to be taken, like site that to be used, the extent of the bleb, and things like that. The type of cataracts that one is operating will determine the extent of the sclera incision and tunneling. All those are important factors that should be considered pre-operative when the patient is examined on anesthesia. One needs to be very proficient in SICS ab initio, and also migrate to perform SICS in the temporal region before you should confidently start operating SICS in glaucoma patients. Avoid complications as much as possible. Complications from cataract surgery is a nightmare in managing glaucoma patient. We need to try as much as possible to avoid this. Goniotomy as MIGS procedure with SICS can be performed easily. Thank you very much. Thank you for listening.